Hi everyone, thanks for joining again. So this is our final session for this week, and this will be on the adrenal axis by Vinay here. So just before we start, I'm just going to explain the house rules as always. If you're in the Zoom and you have any questions, feel free to put them in the chat if they're questions about what's happening right now. If you have any questions that can wait till the end, put them in the Q&A box. And if you're watching on the Facebook, just feel free to comment and read the questions, and they'll be passed on to Vinay, and he can address them when he wants to. Otherwise, everyone, hope you have a good session. I'll pass it off to you.
Fantastic. Thanks, Ehsan. Right. So my name is Vinay. I'm a fourth-year medical student at University of Bristol. And I'm going to be talking to you today on some preclinical physiology and pathology, specifically looking at the adrenal axis. I'm not sure it'll entirely take the whole hour, so it's a bit of a lighter session for you, which makes sense because it's a Friday. So before I really get into all of this, this is going to be primarily for students in their first and second years of medicine, and you can watch it if you're a clinical student, but it might be going a little bit slow for that. If you have any questions, just put it in the chat. I hopefully should be able to answer. Right. So yeah, just a bit of disclaimer from the Become Your Doctor team. So today we're going to be looking at the adrenal gland and the endocrine axis from the hypothalamus, pituitary, and adrenal, and what effect that has on the body. So we're going to look at the hormones that the adrenal gland produces and how exactly they're regulated by the body. We're going to take the adrenal gland and we're going to essentially dissect it, and we're going to look from the outermost shell of the adrenal gland and go from deeper and deeper into the layers of the organ. We're going to look at some of the hormones and what exactly do they do. And finally, we're going to touch on some of the pathologies that might affect the adrenal gland, and just for a little bit of clinical approach to endocrinology as well for you. Always makes things a little bit more interesting. So first, a little bit about the adrenal gland itself. You should know that it sits atop the kidney on the cranial axis of it. And basically, if you take it's a small little gland, but what if it's most importantly, it's a retroperitoneal organ. And before I go into the detail of it, one thing that I always struggled to remember which organs were retroperitoneal and which ones are intraperitoneal. This is a really good mnemonic to use, sad pucker, for any any of the organs that are retroperitoneal. It's these. The only difficult thing to remember is that S is for suprarenal rather than adrenal. Right, so if we take the adrenal gland, we can essentially cut it in half and look at it from a transverse section. And it has this outer capsule, and then the outermost layer, apart from the capsule, is its cortex, and in the middle we have the medulla. Now we can zoom into that microstructure of the adrenal gland, and you can see that the cortex of the adrenal can be divided into three distinct histological layers called the Zona Glomerulosa, Zona Fasciculata, Zona Reticularis, and then finally the medulla, which we've covered before. I'm going to be going through this. I'm going to be kind of laboring these three layers over and over again because I think that's the best way to remember them and try and commit them to memory. Right, so as I said before, we have three layers in the adrenal cortex: the Zona Glomerulosa, the Zona Fasciculata, and the Zona Reticularis. And I think a really good way of remembering this is to use and of course the medulla, is to use the mnemonic EGF or EGFR. And you might remember EGFR from your kidney physiology lectures as a measure of kidney function. It's just an easy way to remember the layers of the cortex. And then in terms of trying to think about what exactly do these layers do, I think about the three layers in terms of salt, sugar, and sex. And the deeper the layers are, the better it gets. So that's just a quick way, an easy way to remember what the layers are. And those three layers, I put it in the corner, and we're going to be going through each of the layers of the adrenal gland and talking about its physiology. Before we do that, a little bit about how the adrenal hormones are regulated. It's a hypothalamic pituitary adrenal axis. So in the brain, we have the hypothalamus and the pituitary, which are intimately linked. And they are important in regulating these three layers of the cortex of the adrenal gland. And the hypothalamus secretes a hormone called corticotropin releasing hormone, or CRH. And what that does is it goes into the posterior pituitary, and that stimulates the posterior pituitary to release a hormone called adrenocorticotropic hormone. So hypothalamus releases CRH, which stimulates the posterior pituitary to release ACTH. And that allows all our hormones, all our steroid hormones from the adrenal cortex to go into the body. And one thing to remember is that all the hormones produced by the adrenal cortex derive from cholesterol. Okay, I hope that makes sense. That's a little bit about the regulation of how these hormones are. So let's go into the layers of the adrenal cortex. And the first one, G from our EGFR mnemonic, we have the zona glomerulosa. Now the zona glomerulosa, as we remember, has got to do with salt, and it secretes mineralocorticoids. So perhaps the mineralo bit makes you think of salts. And that's really dealing with sodium and potassium and the homeostasis of these two ions. The main hormone you need to know about when it comes to this particular outermost layer of the adrenal gland is aldosterone. And what aldosterone does is it acts on the kidneys. It acts on the distal part of the renal tubules to reabsorb sodium. So let's have a look at the function of aldosterone. So like I said before, aldosterone has an impact on the kidneys, and it regulates the salts of sodium and potassium. And what it does is sodium gets reabsorbed back into the body, and as a result, general principle of medicine, wherever sodium goes, water goes. So water is also reabsorbed, as well as a few other ions. And if you remember about kidney histology, there are a couple of different channels. There's the sodium potassium ATPase channel, but there's also that epithelial sodium channel, and it's those particular channels that reabsorb the sodium but also secrete potassium out of the body, and following that, protons are also leaked into the urine. And this is one way in which the body deals with acidosis. So if the body's in has too many protons, aldosterone can be switched on, and that can get rid of these H+ ions and return the pH back to normal. That's just one way in which aldosterone is switched on. So in terms of regulation of aldosterone, if the body has too much potassium in the plasma, aldosterone, it's picked up and the body is stimulated to produce aldosterone to kick it out into the urine. And similarly, if we have a decrease in plasma pH, i.e. acidosis, this is just one of the mechanisms that is utilized to remove excess protons. And the other two factors which switch on aldosterone are increase in angiotensin II and a decrease in blood pressure. Now, if you haven't really covered this in your lectures, I'm going to be going through everyone's favorite physiological cycle, the renin-angiotensin-aldosterone system, and hopefully this will make a little bit more sense after that. So this is really the principal way in which the body can deal with a drop in its blood pressure. So imagine you do have a drop in blood pressure. This might be a drop in blood volume, For example, if someone's had a bleed or something like that, or they might be dehydrated, that can drop your blood pressure. What happens is that the drop in the blood pressure is picked up by cells in the kidneys called juxtaglomerular cells of the kidney. And what this stimulates is production of a hormone called renin. So that's the first part of our Renin-Angiotensin-Aldosterone system. It's pronounced renin, not renin. Renin is a very different thing. That's with double N. You can look up what that does. Renin stimulates the liver to produce a plasma protein called angiotensin-1 from its precursor angiotensinogen. So we have a drop in blood pressure, the kidneys secrete renin, and then as a result, the liver converts angiotensinogen to angiotensin-1. Angiotensin-1 goes off to the lung, so we have kidneys, liver, then lung, and angiotensin-1 is converted into angiotensin-2. And before I go on to how that affects aldosterone, angiotensin, this conversion from angiotensin-1 to angiotensin-2 is carried out by an enzyme called ACE, angiotensin converting enzyme. It's a very important enzyme because in clinical medicine, we have drugs called ACE inhibitors, and they are important in people who have high blood pressure and also heart failure. So a key sort of enzyme to know when it comes to pharmacology. And angiotensin-2 has two functions. One, it acts on various angiotensin receptors in blood vessels, in the heart, in the kidneys, and it can cause rapid vasoconstriction. So that's one way in which angiotensin-2 deals with this rapid drop of blood pressure. The second thing it does is that it stimulates our adrenal glands, which we're learning about, to produce aldosterone, the mineralocorticoid from the Zona Glomerulosa. And as we know, aldosterone causes retention of sodium, and where sodium goes, water goes. So with the retention of water, our blood pressure rises again, and we're able to mitigate any form of drop in blood pressure. So it's a bit of a complex system, but one you have to know about in first and second year, and has a lot of clinical importance when it comes to drugs for hypertension and heart failure. So a drop in the blood pressure causes the kidneys to secrete renin, which fosters this conversion from angiotensinogen to angiotensin-1 in the liver. Then in the lungs we have angiotensin-1 to angiotensin-2, which stimulates the production of aldosterone and water retention, thus mitigating any drop in blood pressure. Okay, so I thought that's enough of me talking. Let's do a poll. Let's do some SBAs. So I think you have it there. So have a read of that. A 59-year-old woman presents to general practice as her friend's been diagnosed with hypertension. She's asymptomatic. You measure her blood pressure as 158/92, that's high. And you decide to do 24-hour blood pressure monitoring. You explain part of the physiology behind blood pressure and the RA system. Which part of the kidney does aldosterone act on? Okay, I am going to end the poll now, because the vast majority of you have done it. Okay. Well done. Vast majority of you got it correct. It's the distal convoluted tubule, so it's the distal part of the kidney that angiotensin works on, and this is the part of the kidney where those channels are for the reabsorption of sodium and water. So like I said, aldosterone acts on the distal convoluted tubule and collecting ducts in the kidneys. And one thing that I think is important for you to know is the drug spironolactone, which is used in heart failure, and it is a direct antagonist of aldosterone. And that's one way it helps for hypertension. So if you put in, what kind of side effects would you imagine spironolactone would have as an aldosterone antagonist? What kind of, if you put in the chat, what would you expect? Gynecomastia. Low BP, oh yeah, that's what you're trying to get. Excellent, hyperkalemia. So if we remember, aldosterone kicks out potassium. If we antagonize that, it means we no longer have potassium exiting the body into the urine, and therefore you can get high levels of potassium in the blood, in the plasma. Anyone know what problems that might cause? It's might be a bit of a tough question. Yeah, so it can cause arrhythmias. It can cause arrhythmias. That's mainly what you say. And then a bit of pathology. There is a condition called Conn's syndrome, and it's essentially a tumor of this outermost layer of the adrenal cortex called the Zona Glomerulosa. And what you get is that you get a lot of aldosterone. You get way too much aldosterone than you need. And as a result, you get these sorts of electrolyte disturbances, too much sodium, not enough potassium, and it can cause these systemic effects like headaches, muscle cramps, lethargy. And aldosterone, as we've mentioned, is important in the regulation of blood pressure, especially when blood pressure drops. So too much of it can cause blood pressure to rise inappropriately, and that's what hypertension is. And when you have hypertension, that massively impacts your morbidity, for your cardiovascular morbidity. That can lead to ischemic heart disease, and it can lead to stroke. So not a nice condition. We go for another SBA. Oh, I've been sharing the poll. So 28-year-old man is shot in the abdomen and hemorrhages. Which one of the following substances will produce vasoconstriction? Okay. All right, so yeah, most of you got it correct. So it's angiotensin 2 that will cause the mass vasoconstriction, the rapid vasoconstriction response. So perhaps if we go back, if I know how to go back. Oh, yeah. So if we have a look here, it's the angiotensin 2 that causes the rapid vasoconstriction, because all across the body we have receptors for angiotensin 2, especially in our blood vessels. Okay, right. So we're finished with the zona glomerulosa, that outside ring of the adrenal cortex. Let's go further deep into the adrenal gland and have a look at the second layer, caused the zona fasciculata. So F is for sugar. Salt, sugar, and the hormones involved here are glucocorticoids. So they're steroid hormones that are important in the metabolism of sugars. The main one you need to know about is cortisol. You might have heard of cortisol because it's the stress hormone. And if we have a look at the levels of cortisol throughout the day, we tend to have this diurnal pattern. So we have more in the morning, and it goes down in the afternoon and evening. And it basically is important in the regulation of our metabolism in stress and in low blood glucose. It has a wide variety of actions, which we're going to go on. It's quite a complicated hormone, but there are a few things that you need to know about it. So here's a really ugly diagram of what cortisol does. So if we have periods of stress in our life, cortisol gets switched on, and it spurs on the liver to undergo gluconeogenesis, so conversion of glycogen to glucose. It breaks down proteins into free amino acids. It breaks down triglycerides into free fatty acids acutely, but we know evidence has shown that cortisol over a long period of time can cause fat deposition all across the body. It suppresses our immune system, and it increases our osteoclastic activity. And osteoclasts are the cells that break down bone. So keep that in mind when we're thinking about cortisol pathology. Like mineralocorticoids, it has a weak effect on sodium and water retention, but it nevertheless has an effect, and it upregulates alpha-1 receptors in blood vessels. So that plays a role in blood pressure. Those are all the sorts of things that cortisol does. So just a bit of a recap. Can anyone put in the chat, what are the regulators of cortisol? What hormones regulate the adrenal axis, and therefore cortisol? Yep, it's not GnRH, but ACTH is correct. It's CRH. So hypothalamic pituitary adrenal axis. From the hypothalamus, we have the corticotropin releasing hormone, CRH, and from the posterior pituitary, ACTH. ACTH is the one that you should remember. So good bit of recap on regulation. And the condition I wanted to talk about in relation to cortisol is Cushing's syndrome. And Cushing's syndrome is essentially increased free glucocorticoids. So you have raised cortisol in the blood. And this description can have this sort of constellation, it can have many different causes of this. And the reason I wanted to talk about regulation of this hormone is because it can come not just from the adrenals, but it can come from the brain itself. So if we have too much ACTH being produced from the pituitary gland, that can increase the cortisol production into the blood and cause this Cushingoid picture, which I'll go on in a minute. So you can have increased ACTH from the pituitary gland. So you might have a pituitary tumor causing far too much excessive ACTH production. Or there's what's known as ACTH dependent Cushing syndrome, which is ectopic ACTH producing tumors. So you can get some tumors, I don't exactly know which ones, can release hormones, and it can mimic Cushing's syndrome. Important thing to remember is if you have a patient with Cushing syndrome and the causation of their free increased glucocorticoids is from the pituitary, that's known specifically as Cushing's disease. You cannot have Cushing's disease unless you have something wrong with your pituitary. So of course it can happen at the high level at the brain, and then of course at the actual level of the gland, the adrenal tumor. So you might have the adrenal glands, or you might have a tumor, or you might have hyperplasia causing far too much cortisol in the body. And it might also be due to exogenous steroid use. So certain conditions, you use steroids as treatments. If you overdo it, you can increase the amount of cortisol in your body, leading to this sort of picture. So these are the symptoms of Cushing's. And I'd like you to think about the symptoms of Cushing's and how exactly they're caused by high levels of cortisol. So if we remember that cortisol chronically causes fat deposition, we can understand why Cushing's patients have obesity around, typically they have it around the back of their neck. It's called buffalo hump, and fat deposition around the abdomen as well. Another thing is osteoporosis. Osteoporosis is caused by that increased osteoclastic activity you get from too much cortisol. That breaks down the bones and causes this low bone mineral density that picture you get in osteoporosis, and that means people with Cushing's syndrome are more likely to get fragility fractures. Hypertension, hyperplasia, you get because of the sodium and water retention you get from too much cortisol, and it can also cause some psychiatric complications like psychosis and depression. I'm not entirely sure why, but it can. So those are the sorts of symptoms you'd expect in someone with Cushing's syndrome. Good, another SBA. Which of the following is linked to excess? Oh, sorry, which of the following is not linked? Oh, no. Well, wonder who's not going to vote that then. Well, someone's been brave and put osteoporosis. Maybe they thought I was playing a trick on you all. Yeah, so it's hyponatremia because we have excess cortisol can lead to it leads to more sodium and water retention. So hyponatremia, it would be hypernatremia if anything. So osteonecrosis and osteoporosis, that's that increased bone breakdown, which you would expect. Good, so yeah, it was hyponatremia. And let's put the next poll on. 65-year-old woman is seen in a respiratory clinic with COPD. Multiple courses of steroids, excessive weight gain, reddening of her face, high blood pressure. What causes, what layer? Okay, the majority of you voted now. Yeah, well done. It is the Zona Fasciculata. Very good. And another SBA. 58-year-old woman presents to her physician complaining of weight gain over the past 2 months. She has not made any changes, but she still regularly exercises. Her face is getting rounder. She has a heart rate of 89, resp rate of 16, high blood pressure, and quite a wide waist circumference, high body mass index. Which of the following describes one of the main effects, one of the effects of the main hormone implicated in this patient's condition? This is quite a difficult one. Okay, I'm going to end the poll here. So well, a lot of you were kind of right. You were kind of mixed between the potentiation of the immune system and upregulation of the alpha-1 adrenoreceptors. So the correct answer was upregulation of the alpha-1 adrenoreceptors. And this is quite a challenging question, I think. So the main thing that you see here that kind of is indicated in the question is you see decreased gluconeogenesis. You would not have that in hypercortisolemia. Cortisol increases gluconeogenesis, so it wouldn't be that. Potentiation of the immune system. Increased, let's just rule out some of these. Increased activity of the osteoblast. Doesn't really complain. First of all, it wouldn't be increased activity of the osteoblast. It would be increased activity of the osteoclast. So you would rule that one out. Stimulation of fibroblast activity. Rule that one out. That doesn't really work with the question. The main thing that we're looking here is that she has a really high blood pressure, 160/84. And the only one that really relates to blood pressure is the upregulation of the alpha-1 adrenoreceptors. That's one of the main reasons why Cushing's syndrome causes hypertension. Is one of the secondary causes of hypertension. Potentiation of the immune system. I'm just wondering why you guys thought to put that. I guess there isn't really any indication here that there's a problem with her immune system. She doesn't really complain of your classic symptoms of infection or anything like that. I think the main thing to pick up would be the blood pressure finding. The hormone here involved is cortisol. Sorry, I probably didn't make that clear. This is a case of Cushing's syndrome. So she has weight gain, weight gain, moon face, high blood pressure, high body mass index. She's gaining weight even with normal exercise. So the cases of Cushing. So this is I understand it's quite a challenging question because it forces you to diagnose just from the clinical picture and then think about the pathophysiology behind what's causing it. But it was Cushing syndrome causing high cortisol and an upregulation of these receptors, increasing the blood pressure. I hope that makes sense. Okay, so now we've had a look at the first two layers of the adrenal cortex. We've had a look at the Zona Glomerulosa, which deals with salts, the Renin-Angiotensin-Aldosterone system, and the regulation of blood pressure mainly. We've looked at the Zona Fasciculata and the role in sugars, cortisol, and Cushing syndrome. The last zone of the adrenal cortex is the Zona Reticularis, and that is to do with sex hormones, and also known as androgens. So the Zona Reticularis in the adrenal cortex synthesizes the precursors to sex steroids called androgens. And the main ones you need to know about are 1-dehydroepiandrosterone and androstenedione, DHEA and androstenedione, and they are the precursors to testosterone and estrogen. So these sort of precursors to androgens are released from the Zona Reticularis, and they are peripherally converted to sex steroids, which are important in developing secondary sex characteristics in puberty. So DHEA and androsterone are converted into dihydrotestosterone and estrogen. And sort of important fact for you to know is that this layer of the adrenal gland is important in postmenopausal women. Because in postmenopausal women, you're no longer producing estrogen from your ovaries, and the conversion of DHEA to estrogen is really the only source of androgen synthesis in postmenopausal women. So this slide might seem a little bit complicated. It's about the biosynthesis of adrenal hormones. So like I said from the very beginning of the presentation, all hormones produced by the adrenal cortex all derive from cholesterol. And we have one pathway looking at aldosterone synthesis from the Zona Glomerulosa, one pathway going and forming the cortisol from the fasciculata, and then we have the final pathway looking at androgen synthesis or precursors to androgen synthesis. And you're probably wondering, you know, do I need to know this? The only thing that you really need to know about this is this enzyme, 21-hydroxylase. And it is the enzyme that converts progesterone to aldosterone, or the precursors to aldosterone, and 17-alpha hydroxyprogesterone to the cortisol synthesizers. Now, this enzyme is important for you to know because it can be, there is a condition in which the enzyme mutates and does not work. And that's called congenital adrenal hyperplasia. Congenital adrenal hyperplasia, or CAH. It is a mutation in that enzyme, 21-alpha hydroxylase, or the vast majority of CAH conditions are mutation in this enzyme. And as a result, we do not have the glucocorticoid and mineralocorticoid production. So we no longer have production of aldosterone, no longer have production of cortisol. What we do have is that we have an excess of androgen production. So if we have a look back at this diagram, these first two paths are blocked, but this last path, we have an excessive amount of it. So that's what happens in congenital adrenal hyperplasia. And as a result of the excess testosterone, in babies, you see a masculinization of the female genitalia. You have a hyponatremia because we don't have aldosterone, hypotension, hypoglycemia, and causes salt losing crisis. That's all you really need to know about CAH. So, can you recap the previous slide quickly? Yeah. Which slide? This one? Yeah, that's it. The previous slide. Yeah, the pathway. Yeah. So this, in terms of what you need to know about the synthesis of adrenal hormones, they're all derived from cholesterol, and the important enzyme you need to know is 21-hydroxylase, because it stops the production of aldosterone and cortisol. So those first two columns, the yellow and green column, and you have excess production of the red column. So you have increased testosterone causing these particular clinical manifestations. Okay, so we are done with the adrenal cortex. We've looked at the zona glomerulosa and its role in salt homeostasis, the zona fasciculata and sugar homeostasis, and we've looked at the reticularis and its role in sex steroid homeostasis. Now let's have a look at the very core of the adrenal gland, the medulla. So the medulla contains chromaffin cells. They're specialized cells for the synthesis of catecholamines. And the catecholamines in question are adrenaline and noradrenaline. So if you're ever asked, you know, tell me about the function of an adrenal gland, hopefully you should be able to go through G, F, and R using the salt, sugar, sex structure that I've given you. Then you might struggle a little bit with medulla. Just think, why is it called the adrenal gland? Because it produces adrenaline. So it produces these things called catecholamines. The main example is adrenaline, and they're all derived from the amino acid tyrosine. Important thing to know, where the zonas of the adrenal cortex are all mediated by that HPA axis, the hypothalamic pituitary adrenal axis that we mentioned before. The medulla is not. The medulla is on its own. I'm pretty sure it's embryologically separate to it. So like I said, the medulla produces the adrenaline and noradrenaline, and it's essentially the ganglion to the preganglionic fibers from the sympathetic nervous system. It directly innervates these cells to produce adrenaline and noradrenaline. So it's all got to do with this fight or flight response of the sympathetic nervous system. So the sympathetic nervous system innervates these cells to produce these hormones. Yeah. And this is important for you to know because there's a condition that's pretty rare called a phaeochromocytoma, and it is excess adrenaline produced by the adrenal medulla. And the reason why that is because it's a neuroendocrine tumor of the adrenal medulla. And when you have more cells, you have more production of the hormone. Perhaps a differential diagnosis that's pretty rare is that you have these things called paragangliomas. They're found in the head and neck, and they can also increase adrenaline. Bit of a side note, probably you don't need to know about that. And it's diagnosed in using a urine sample. VMA is a metabolite of adrenaline, and that's picked up in the urine. But of course, the clinical pictures you'll know first. And here's a pathology specimen of phaeochromocytoma. If you see this, in one of those pathology pots in your anatomy school, you can see that they're in the middle of the adrenal gland. You have this kind of white area, suggesting that there's some sort of tumor or growth in that area. You know, it's right in the middle. It's part of the medulla, and it's probably causing a lot of adrenaline pumping around the body, far too much adrenaline. So you might want to think about what sort of symptoms. VMA is a metabolite of adrenaline. I can't exactly remember what it stands for. I might have to look that up, but it's what's picked up in the urine in phaeochromocytoma. So in terms of thinking about what kind of symptoms you might expect from phaeochromocytoma, can people just put in on the group chat what sort of symptoms you'd expect? Loads of adrenaline, loads of sympathetic drive. What would you kind of expect these patients to get? Hypertension, good, yeah. Yeah, good. Anxiety, very good. Good differential for anxiety. Headaches, yeah. Sweating. Weight loss. Good. So we're all putting fairly similar things down. I've taken this from a study about childhood phaeochromocytoma. It's just a bit of evidence as to what these patients get and what is more common. So things that you guys mentioned: hypertension, sustained hypertension, sweating, headaches, palpitation, weight loss, vomiting, all these sorts of indicators of a high sympathetic drive because there's way too much adrenaline pumping around. You know, that's what you'd be thinking about when you think about phaeochromocytoma, although it's pretty rare. Right, let's do another SBA. "58-year-old with type 2 diabetes presents to his GP with anxiety, sweating, and palpitations this morning. Pale and clammy with mydriasis, which is the pupils dilating. Increased bowel sounds. He's been on gliclazide for his diabetes, which is a new drug for him. And I've given you a bit of a clue as to the primary biological site for the synthesis of this hormone. When you think about what kind of picture, think about what might be causing anxiety, sweating, palpitations, all that sort of thing. It might even be what we just talked about. Okay, majority of you have put in the poll. Well done. Yep, it was the chromaffin cells of the adrenal medulla. So if we have a look at the, it perhaps is a little bit easier because we've literally just talked about phaeochromocytoma. But the clinical picture here is really classic of high sympathetic drive. And in terms of thinking as to why this has happened, it probably is because he's hypoglycemic. So he's just started a new medication for his diabetes. The stress response and the hypoglycemia kicks into action. and that causes adrenaline to be released from the chromatin cells of the adrenal medulla. Well done. And I think this is the last SBA. 42-year-old gentleman is diagnosed with Phaeochromocytoma. Which of the following amino acids are the catecholamines primarily produced from? Oh. I think accidentally. Oh, yeah. Is the poll still there? Okay, yeah, good. Ending the poll. Yeah, good. Tyrosine. Just one of those little facts that medical schools love testing you on for some reason. Good, tyrosine. Okay, so we have gone through all of the zones, the different layers of the adrenal glands. Last thing I wanted to touch on is a condition called Addison's disease. And what Addison's disease is hypoadrenalism. So it's complete destruction of the adrenal cortex, not the medulla, only the cortex. And as a result, your glomerulosa, fasciculata, and reticularis aren't functioning properly, and you have low aldosterone, low cortisol, low androgen levels. And because you don't have the negative feedback back up to the posterior pituitary gland, high levels of ACTH. And as a result, you get this sort of picture. You have low blood pressure and weakness because you don't have the aldosterone causing your water retention and sodium retention. As a result, the patients might fall over because they get postural hypotension because they're lacking enough volume in their blood. They're weak, that causes the gastrointestinal system symptoms that you see here. A pretty classic sign that you'll see is hyperpigmentation of the skin, so-called bronze hyperpigmentation. So you can see a picture here. Have a look on Google, have a look at a few other pictures of, or DermNet is a very good website for skin pictures, skin pathology. That's bronze hyperpigmentation. It's pathognomonic of Addison's disease, and it's a result of the increased ACTH levels because you don't have the negative feedback. All right, so that was nearly 50 minutes. So just a bit of a summary. We've gone through the 4 levels of the adrenal gland, the Zona Glomerulosa, when we've looked at the aldosterone system and the RAA system. We've looked at spironolactone and Conn syndrome. We've looked at the Zona Fasciculata, its role in cortisol and sugar metabolism and how it goes wrong in Cushing syndrome. We've had a look at the Zona Reticularis and androgen synthesis and function, sex steroids. And we've finally had a look at the medulla, the very core of the adrenal gland, looking at its role in production of adrenaline and phaeochromocytomas. So that's where things go wrong. And lastly, we've looked at hypoadrenalism, where the adrenal cortex goes wrong. Okay, please do put in feedback. I'm hopefully going to be teaching on this again, so I'd love to know what I did right and what I did wrong. That'd be really useful. I'm going to try and answer a few questions. Please forgive me if I don't know the answer. Okay, so from the start you mentioned Sad Pucker. What type of organ was that for? Retroperitoneal organs. So abdominal organs are organized, as it were, sorry for the pun, into intraperitoneal and retroperitoneal, and that, yeah, don't know, yeah. And yep, how does cortisol lead to hyponatremia? It does. It has not as much as aldosterone does, but it acts and it causes some form of sodium and water retention. So if you don't have that retention of sodium, you get hyponatremia. I'm just going to have a look at the Q&A section as well. why does the fat deposit on why does it go on the abdomen and the back of the neck? I don't know why those are the specific points. It's a sort of like the classical presentation of Cushing syndrome is you get moon face, buffalo hump, and truncal obesity. They're just sort of really classic descriptions of Cushing syndrome. I can't tell you the reason why it's exactly in those areas. Great. I think I've answered all of those questions. If you have any other general questions about, you know, clinical medicine, life as a medical student, exams, medical school, whatever, I can try and answer a few of those questions, but if not, that's fine. Does cortisol increase excretion of potassium then? Not that I'm aware of. I don't think so. Okay. If there are no other questions, I think we're okay to end there.